I think this part of the session would have been better as a wet lab session because it's all about access, but I'll have to try and illustrate as much as I can through slides, and I hope to do that as best as possible. We've heard already that TAVI is expanding. We've done all the high-risk cases now. Intermediate cases are basically good part of patients are intermediate risk, and some talk about low-risk group. And I think access is going to be one of the most important sort of decision-making process, because as you will see through the talk, if we go to transfemoral, then easier access, easier recovery, and you'll find that TAVI will become one of the most performed procedure for aortic stenosis. So I'll hope to cover these various access points today. So we'll start with the transfemoral. We are surgeons, we've learned anatomy at medical school, and we've had a few patients where we've done a transfemoral cannulation, maybe in a dissection case or for the odd minimal access case that we've been involved with. But the transfemoral access remains the most common access route in the TAVI world, over 90% nowadays, especially with the devices that we have on the market. Ganesh has already mentioned the 14 French equivalent. These are really very small devices, and transfemorally they work very, very well. There are a few things, a few provisos though, when we come to transfemoral access, and I think it's important that we assess the access point appropriately with a CT scan with contrast. And the few things that you want to be aware of and you want to find out before you get down to doing your TAVI is, first of all, the size of the artery. It's very rare to have very small femoral arteries in our patient group, but sometimes you do see them. And I think if you get femoral arteries less than 5.5 centimeters and you have big devices, you will struggle to get them up the femoral artery. The other issue is you look at calcification at your puncture site. Most of us will be using a percutaneous approach with closure devices such as Broglide or ProStar. And if you have a lot of calcium, then you will get into trouble when you get to the closure site. The third thing is about the bifurcation of the femoral artery. You want a bifurcation which is quite low, so that where you puncture, you don't get into trouble in obstructing the side branches. And then finally is about tortuosity. The more tortuous the iliacs are, the more tricky it is to get your TAVI devices up the aorta. And obviously there are tips and tricks using buddy wires and more stiff wires to try to straighten these tortuous vessels. But overall, the picture you see on your left is something you definitely should avoid, and probably refer to a friendly cardiac surgeon to help you with an access elsewhere in the body. The device itself, the delivery of the TAVI through the transfemoral route is very easy. Most of these procedures take under an hour, and I think in our practice, the access point, if it gives us trouble, probably takes longer to sort out than actually delivering the TAVI valve. In terms of complications, when you go transfemorally with the VARC criteria, you could say there's about 5 to 10% complication rate. This is what we quote our patients in the consent. Most of them are minor issues with just a leakage around the puncture site, but occasionally you can get into bigger problems. And most commonly you will find that you get into bigger problems because you haven't planned for it. And these will be things like dissecting the vessel, or even disrupting the vessel and disconnecting it from the aorta. Occasionally you will get a pseudoaneurysm, but that again, if you are careful enough when you're closing and making sure that there is no leak at the end of the procedure when you do your final check angiogram. The access where surgeons are mostly required are the surgical access areas, the subclavian artery or axillary artery. We use the left subclavian approach. In our practice, it's about 3 to 5% of the population that will get a left subclavian approach. It's very actually easy to do. Before I started doing it, I always thought, gosh, where is it? Where will it be? But actually, it's something that I really enjoy doing now. Again, here, just like with the femoral, a few provisos. Just be careful about the brachial plexus. They do look like a vessel, and they do transmit pulsation. So if you put your finger on it, you might think it's actually the artery, but it isn't. But so long you're careful, you can easily access it. Some people use a graft attached to the artery and then deliver the device to the graft. I just go directly through the artery. On one occasion, I've had to patch the access point, but on the other occasions, just a direct closure surgically has worked quite well. What is great when you're doing TAVI and subclavian access is you have a hybrid sort of setup. So you can give some contrast down the arch, and you know exactly where the artery is even before you start cutting on the outside, and you can just go straight down onto it. And then once you've got the device in, the delivery is fairly straightforward. The one thing I would say though is most of our TAVI delivery systems are devised to be used transfemorally. So you end up with this really long sort of snake that you have to have 3 people behind you holding the device so that you can actually keep it sterile and deliver it properly. Direct aortic, very rarely used, but again it's one of those that can be used. I use an inverted J mini stenotomy. It's fairly straightforward. I have to say the outcome of the patients having a direct aortic compared to transfemoral is a longer recovery period, more pain, take a bit longer to be discharged from hospital. So we really use this as a sort of a last resort. The problem I find mostly with the direct aortic is one, the sheath that you have is not really made to be used in that position. So Boston, I think, came up with a sheet which had some markers on it to guide you. We've actually gone sheathless when we're doing direct aortic, and it's worked quite well for us. Similarly, as with the subclavian approach, because it's so short from your operating access area to the device delivery area, you have to have a couple of people behind you supporting the device. But it works very well once you get in there. Trans-Apical, I'm not too sure whether anybody is doing Trans-Apical anymore for TAVI. It is much more invasive, and the Achilles heel is certainly the entry point in the ventricle, which can give you a lot of trouble in terms of bleeding and occasionally pseudoaneurysm formation. However, the Trans-Apical approach probably will become more popular again once the mitral valve prosthesis get on the way. But I think for TAVI itself, very few or very rarely we are having to use the Trans-Apical approach. It's fairly straightforward once you deliver the valve. I think the most important part when you do a Trans-Apical approach is to get good suture, pleated sutures around your apex, and so that at the end you don't have to deal with a big hematoma that forms within the ventricular muscle. So these are probably the most current used access points for TAVI delivery, with the transfemoral being the majority of them. Some of sort of previous teams have used a carotid artery approach. I'm not too sure how much it will remain popular, and I think it sort of died a bit of a quiet, painful death. And it's not used very much anymore. But the one thing that is actually getting some press is the TransCAVAL approach, and that's going through the femoral vein and then accessing the aorta by creating an arteriovenous fistula in the abdominal area, and then delivering your device through that route. And when you finish, you have like an umbrella device to close the arteriovenous fistula. How popular it will become, I'm not too sure, given that most of the TAVI devices now have become quite small in terms of their delivery size. But there may be a place for these where you do have some patients with quite severe lower peripheral vascular problem, and probably just the abdominal or higher aorta is accessible for a good access to deliver the device. Yeah, they just summarize the various steps in the TransCAVAL. It looks very complicated to me. I haven't tried it, but it's been described. I think overall we will find that the transfemoral approach remains the approach of choice. It's the quickest recovery. Most of these cases are done under local anesthetic and sedation, and most patients, if they don't need a pacemaker, will probably go home on day 2, day 3, I would think. Is that right, Ganesh? Probably same in your practice. Next day. Thank you very much.